Good afternoon.
Good afternoon.
You know, this gets better and better. And by the time I've been at Harvard 40 years, I'll say good afternoon, and everyone will know you're supposed to respond. Good afternoon.
Good afternoon.
Oh, thank you. You do my heart good. You do my heart good. My name is Dr. Joan Reed. I'm Dean for Diversity and Community Partnership here at Harvard Medical School, and so pleased that you've been able to join us today for our Alvin F. Poussaint visiting lecture. You know, Dr. Poussaint is a hero and an icon within Harvard Medical School in our community. He's a professor of psychiatry emeritus, was a faculty associate dean in student affairs until his retirement in 2019. He was actually the founding director of the Office for Recruitment and Multicultural Affairs, the initial iteration of that going back to 1969. We know him as the author of books, of articles, someone who has served as a consultant and wise counsel for government to private agencies to the media, that he is a true social commentator on race relations in America, the dynamics of prejudice and issues of diversity in our society. He hailed from East Harlem, attended Columbia University and Cornell Medical School, and trained in UCLA in psychiatry. But really, I think part of his roots and his grounding is when he served as a Southern Field Director of the Medical Committee for Human Rights in Jackson, Mississippi, from 1965 to 1967. Such a foundational member of our community in terms of advancing issues around equity and excellence. He's a distinguished fellow of the American Psychiatric Association, the American Association for the Advancement of Science, a life member of the American Academy of Child and Adolescent Psychiatry, a member of the American Academy of Arts and Sciences, and beloved professor here at Harvard. He's not able to be with us here today. And this Alvin F. Poussaint, MD visiting lecture was really started at Harvard Medical School in 2004 as an inaugural gift from HMS alumni in honor of Dr. Poussaint, recognizing his importance in their careers and their education and their early development. The purpose of the fund is to provide an annual lecture here at Harvard in a forum for connecting our Harvard alums and leaders in medicine and science with our students and our residents and our fellows and our faculty across our institutions. And our lecturers are individuals who have had an affiliation with Harvard, be it as students or residents or faculty in our hospitals. And this year marks our 19th annual Poussaint lecture with our 18th visiting lecture. Of course, Dr. Poussaint was the first visiting Alvin Poussaint lecturer. He's not able to be with us today, but Dr. Tina Young Poussaint is. And Dr. Tina Young Poussaint is the radiologist in chief, the Lionel Young Chair of Radiology, and professor of radiology at Harvard Medical School. And I invite Dr. Poussaint to say a few words.
Oh, great. Thank you, Joan. It's really a pleasure to be with all of you today. My husband, Dr. Alvin Poussaint, is deeply honored to have this lectureship, which invites distinguished Harvard Medical School alums like Dr. Yvette Roubideaux, who have shaped clinical standards, innovation, policy reform, and education. These alums inspire future and current leaders to pursue the values of excellence, advocacy for patients, and our ability to navigate our complex medical systems with integrity and compassion. So I thank her for being here, and I really thank Dr. Joan Reed for really shepherding this lectureship. I know my husband is very, very grateful for this, and truly it has been a pinnacle of his career that this was established. So thank you very much.
Thank you. And thank you for being with us here today, and give him our best. It is now my pleasure to introduce our 23-24 Poussaint lecturer, Dr. Yvette Roubideaux, a physician, researcher, public health advocate, an enrolled member of the Rosebud Sioux tribe, and is descended from the Standing Rock Sioux tribe, an adjunct professor in the Department of Health Systems Management and Policy at the Colorado School of Public Health. Dr. Roubideaux previously served as Director of Policy Research Center at the National Congress of American Indians, where she conducted and translated policy research and data to improve outcomes for American Indian and Alaska Native tribal nations. Her work at NCAI included the quality of census data, Native vote data, data disaggregation, COVID-19 data trends, research on diabetes and AIAN, and education on tribal governance of research and strengthening tribal academic research partnerships, really across the board. She has served on the Obama administration as a senior advisor to the Health and Human Services Secretary for American Indians and Alaska Natives, and as the director of the Indian Health Service. Prior academic appointments include clinical professor and associate dean of diversity, inclusion, and leadership at the Elson S. Floyd College of Medicine, Washington State University, and assistant professor at the University of Arizona College of Medicine and Zuckerman College of Public Health. She's been the co-director of the Coordinating Center for the IHS Special Diabetes Program for Indian Diabetes and Cardiovascular Disease Prevention demonstration projects, and directed training programs to encourage American Indian and Alaska Native students to enter health and research professions. She's a founder of the Native Research Network and served as president of the Association of American Indian Physicians and is an elected member of the National Academy of Medicine. She's had a little bit of contact with Harvard in the past, just a little bit. She received her undergraduate public health and medical degrees here at Harvard. That's like a triple H, okay. And author of many publications. And she was an inaugural fellow from 1989 of the Commonwealth Fund Fellowship in Minority Health Policy. And I present to you Dr. Yvette Roubideaux.
Thank you so much. Good afternoon, everybody.
Good afternoon.
It is so great to see you here. Thanks so much for coming on this rainy day. You know how that goes in Boston. I'm having flashbacks and nightmares a little bit. I don't have to walk in the rain anymore, so that's the best part. Well, thank you so much, Dr. Reed, for that really kind introduction. And I want to thank everybody who got me here. I know Jorge Fortin, excellent job. He got me here. And I want to thank the nominating committee members who were involved in selecting me for this honor. And I just want to give a special thanks to Dean Professor and Dr. Joan Reed. She's been my mentor for almost 30 years, and I really owe her so much gratitude and so much thanks for helping me and helping so many others. So thank you so much. So good to see Dr. Reed. And I do want to say for Dr. Poussaint, I am so honored to speak in this lectureship that honors his lifelong work and commitment. And it was so great to see the amazing Tina Young Poussaint on the video. Great to see you, and send my great thanks and admiration to Dr. Poussaint.
I will.
Well, thank you. Well, today I'm going to talk about some of my work improving healthcare for American Indians and Alaska Natives, and how I think we're all trying to help heal a broken promise. And I have no disclosures to share. First, I wanted to acknowledge that I think the last time I saw Dr. Poussaint was in person in 2005 at the when he delivered the inaugural keynote, and there was a symposium to honor this lectureship. And so as Dr. Reed knows, I save everything. So I have the actual agenda. I have the thank you letter from Dr. Reed and a thank you card from Dr. Poussaint. But I actually have to say that the most exciting part of the event was this event helped me meet James Taylor. So anyway, thank you so much for that as well. I had to throw that in. Well, also, I just read the new book, the New York Times bestseller, Legacy by Dr. Uche Blackstock. And I recommend it to everyone. Actually, every medical school should require it. But she mentioned Dr. Poussaint early in the book, as you may know. She said what I felt about Dr. Poussaint when I was here as a student. She said, with open arms, Dr. Poussaint welcomed me to medical school. And Dr. Poussaint always seemed to have time to counsel us and hear about our latest news. And his office gave us a place to call home at Harvard Medical School. And thank you to Dr. Poussaint for making this place a home for me and so many others. So what's this broken promise that I'm talking about? Well, this promise is the federal trust responsibility. And the federal government has promised to provide certain services and benefits to American Indian Alaska Native tribal nations as a result of many treaties, laws, Supreme Court decisions, and policies that have been enacted. And this responsibility includes healthcare. And this responsibility is in exchange for the lands that were lost for my people and the ways of life that were lost. And this promise is legally binding. But make no mistake, this promise is broken. American Indian Alaska Natives still overall suffer many significant health, social, and economic disparities. And there is still so much for the government to do to live up to that promise. And tribal organizations and leaders like those in this famous NCAI picture that I found in my father's files, these tribal leaders and these organizations have been going to the administration, to Congress every year for decades to hold the federal government accountable to this federal trust responsibility. But unfortunately, the promise is still broken. Now I know that the federal trust responsibility or the promise is broken when I think about my family and my ancestors. Well, I'm American Indian. I'm also a little German and French. I'm a member of the Rosebud Sioux tribe, which is my father's tribe, and I am descended from the Standing Rock Sioux tribe, which is my mother's tribe. And this is a picture of my mother's grandparents. So they are my great-grandparents, and their names are Annie and Augustus Makes Trouble. But those are their English names, or his name was actually Makes Trouble when he was born. And this picture is from probably about the early 1900s. And I really love that my mom's family name is Makes Trouble. Sounds like a good legacy. But you know what's amazing is they survived the Indian wars that ended in the late 1800s, and he fought in them. And they survived the difficult transition of losing their land and their entire lifestyle. I mean, really all of their social determinants were suddenly gone. However, they did survive, and my parents and me are proof of our family's survival despite so many challenges. And my parents grew up very poor on their reservations, and they were forcefully taken away from their homes to go to Indian boarding schools. But despite this, my parents survived, and my mom became a nurse and my dad became a lawyer. So it seems like I hit the social determinants jackpot, but actually that doesn't mean it was easy for them, and it doesn't mean it was easy for me. But however, we do continue the line of resilience and strength from our ancestors. And that's the thing about Native students that come through these halls. You may have noticed that some seem particularly driven towards helping their people. And that's because we know this history. We want better health and a better future for our people. Now, I do want to point out at the beginning of this presentation that American Indians and Alaska Natives are a very diverse population. Overall, they're impacted by significant disparities, but individually, there's quite a bit of diversity. The first level of diversity in how they identify themselves is in these circles. First, there's a lot of people who self-identify, but then within that are people who have proof of tribal descendancy. And then within that are American Indians and Alaska Natives who, like me, are members or citizens of their tribal nation. And this impacts access to healthcare and other resources. So for example, only tribal members and descendants are eligible to receive care in the Indian Health Service. Not all American Indians and Alaska Natives. It's a common misconception. Then the next level of diversity is related to all of these other factors, which include differences in socioeconomic factors, differences in culture and language, and also differences into things like access to healthcare, coverage, and services. And really, physicians and researchers need to think of these kinds of factors when they work with American Indians and Alaska Natives, and to not make assumptions. So for example, if you do research, a sample of urban American Indians and Alaska Natives can be quite different than a sample of rural reservation-based American Indians and Alaska Natives. Individual patients, for example, can vary widely among all these factors. It's important not to make assumptions. And so practicing cultural humility is extremely important with American Indian and Alaska Native patients. The focus of my work has generally centered around American Indians and Alaska Natives who access healthcare in the Indian Health Service. The experiences and challenges of American Indians and Alaska Natives accessing healthcare outside of the Indian Health Service, that's a whole other lecture. So today we're mostly focusing on Indian Health Service eligible. And the picture on the slide shows the IHS facility that I went to as a child in Rapid City, South Dakota. And the Indian Health Service, or IHS, is a federal agency responsible for providing healthcare and other services to members or descendants of 574 federally recognized tribal nations. And it's now a healthcare system of almost 600 hospitals, clinics, and health stations that are managed by IHS, tribal nations, or urban Indian health organizations. So it's not all just IHS. The tribal organizations and the urban Indian organizations also manage those programs. And IHS is a part of the federal trust responsibility. So if an American Indian Alaska Native is eligible, they can access the Indian Health Service and get free health care. Sounds good, right? Well, not exactly. I used to hate going to the Indian Health Service as a child, since it was always long waits and always different doctors. And I also heard many stories from my relatives about the poor quality of care that they received. So that's why I became a physician, was to try to help improve the quality of healthcare for American Indians and Alaska Natives. So fast forward to the 1980s. I know some of you weren't born, but go with me. In the 1980s, I ended up at college at Harvard University as a pre-med, and eventually here at Harvard Medical School, class of 1989. And this is a picture of me at my medical school graduation with my beaded stethoscope that my grandmother had made for me, which was a big hit. I made the Focus newsletter. And then also, this is a picture with some friends from medical school. I believe at our 25th reunion on the right, we used to study together and support each other. And Dr. Davis is here today, Carmen Davis. We've been friends since medical school. We go way back. So another thing about this picture, which I really love, is that we were posing in front of the statue. And that was really important choice for us because we were not reflected in the paintings and statues in the halls back then, but we are a part of Harvard now. Well, when I was in medical school, I had the opportunity to attend a meeting of the Association of American Indian Physicians in my third year. And that helped me so much because I finally got to meet American Indians, Alaska Natives who were physicians and who were actually practicing medicine out in tribal communities and who shared the same goals that I had. And this really helped me at the time. So these pictures are from the year 2000 when I was the president of the organization and I led the meeting. And I also led the grand entry at the powwow. And this organization is really great because it's a safe place for us also to share our culture and traditions. So if you know of any Native students interested in becoming a physician, have them Google this organization. They can get free travel scholarships to the meeting, and it's really a great opportunity. So fast forward to my internal medicine residency at the Brigham, I finally ended up working as a physician in the Indian Health Service at the San Carlos IHS Hospital in Eastern Arizona in the early 1990s. some of you still weren't born. But anyway, I got to see the challenges of being a physician on a rural Indian reservation with a tribal nation that was somewhat different from my own, but also faced similar health challenges. And on the left, this was an article in the 1995 HMS Dean's Report. Just thought that was fun. At the time, in the early 1990s, the hospital pictured here was already 30 years old. It had limited inpatient beds, a small clinic, and a small emergency room, with only half of the number of physicians needed to serve 10,000 people in the local San Carlos Apache tribal community. And that's the issue with the Indian healthcare system, not enough funding or resources for the demand for care. I really loved working at San Carlos. It was an amazing experience, but after 3 years, I was pretty burnt out with the lack of staff and resources. And when you see these disparities every single day, it certainly is a big challenge. And the promise was way more broken than I had thought. So I wondered if I could do more to help. So I also learned about this new hopeful trend in the 1990s in tribes taking over the management of healthcare facilities previously managed by the Indian Health Service. And then I worked at the Gila River Indian community, the Pima Indians, for a year after at San Carlos. And I got to see the tribe actually take over the management of their healthcare facility right then. And it was a promising trend that I was really excited about. Then I hit the jackpot again. In my mail, right at that time that I decided I needed a career change, I found a brochure. They used to send things in the mail back then. So I got this brochure for a new fellowship program. And it's the Commonwealth Fund Harvard University Fellowship in Minority Health Policy at Harvard Medical School. It's the name we had then. And it was in the first year of the program. And this is the beginning of Dr. Reed's vision for this program. And this year was critically important for me to get my MPH degree and also learn how I could help to improve American Indian Alaska Native healthcare as a physician, but also in a policy role. And the most important lesson I learned from Dr. Reed was, you know, I could do this work in many different roles. And that's actually what I happily did throughout my career. Another important lesson that I learned from Dr. Blandon in my MPH classes was Dr. Kingdon's framework, and I've adapted it here, that described how you need data on the problem and data on its potential solutions. And those are critical parts of the policymaking process. And at the time, I knew we had a lot less data on American Indians and Alaska Natives and their health compared to other populations. So I surprisingly suddenly decided I need to be a researcher so that I can get the data needed to inform policy for our population. So that was a big surprise because I'd never done research before that. And I had to learn how to be a researcher. So I did some advanced training after the fellowship. I want to tell you about this great program. It turned out I hit the jackpot again. Another new program was starting that was ready for me just at the right time. Dr. Spiro Manson and Dr. Deidre Buchwald in 1998 started a research training program called the Native Investigator Development Program. It wasn't a response to the problem that there were few American Indian Alaska Native researchers at that time. Only 9 American Indian Alaska Natives were principal investigators on NIH grants. And there was generally a lack of role models for American Indians and Alaska Natives to help mentor early career American Indians and Alaska Natives to prepare to be independently, externally funded scientists. So this National Institute on Aging funded program was an intensive 18-month training program, including statistical training, conducting a descriptive study, a pilot study, and writing an NIH grant. And the Native researchers did all this while still at their home institutions, but traveled to a centralized training site on a regular basis. And that really helped because a lot of American Indian Alaska Native physicians and researchers don't want to move away from their homes and their family. And so the program, however, was very rigorous, but it was really successful. And I could not have become a researcher without it. And it's a model for other programs. And Dr. Manson and Dr. Buchwald are still cherished mentors and friends to this day. Well, the outcomes of this program are really amazing. So many of the Native investigators went on to be tenured the entire cohort received millions of dollars in research funding and published as a group over 600 peer-reviewed articles. And compared to the original 9 Native PIs in 1998, in 2009, there were 132 NIH grants that had American Indian Alaska Native principal investigators or project directors, and 50% of them were alums of this training program. And all the research that these Native investigators are doing are helping improve the health of American Indians and Alaska Natives. So my first job after the fellowship, when I started that program, was as faculty at the University of Arizona in the College of Public Health and in the College of Medicine. And I was there for 11 years. I conducted research on diabetes in American Indians and Alaska Natives. I taught about American Indian Alaska Native health policy. I led programs to recruit American Indian Alaska Native students into health professions and research careers. And I worked with tribal leaders on health issues. And of note, I'm really proud to say that some of the students in these pictures went on to become physicians or researchers or health professionals working in tribal communities. They were there when COVID hit. I'm really very proud of them. So my research and policy work at the time focused on diabetes in American Indians and Alaska Natives. And this slide shows the latest data from the National Diabetes Statistics Report from 2019 to 2021 with 2021 IHS data. And American Indians and Alaska Natives still have the highest rates of diabetes compared to other racial and ethnic groups. Unfortunately, this has been true for decades, but there have been some improvements, and that's what I'm going to tell you about next. And I've really been fortunate to be a part of that work. I had the opportunity to work with many others on the Special Diabetes Program for Indians, or SDPI, during that time. And this is now $160 million per year congressional appropriation to help prevent and treat diabetes in American Indian Alaska Native communities. It's a community-led project with tribal leaders guiding it from the beginning, and it has amazing outcomes, even now after 25 plus years. The Special Diabetes Program for Indians expanded access to quality diabetes care in tribal communities based on the implementation of evidence-based best practices in diabetes care, and many outcomes improved over time. The best news of all is that during the same time as the period as the SDPI, diabetes prevalence in American Indians and Alaska Natives stopped increasing and actually decreased from 2013 to 2017. And so this program has had an amazing impact. And the other great news is that diabetes mortality for American Indians and Alaska Natives decreased by 37% over the same time period as this large program called the SDPI. And one of the most notable improvements I hope you've heard about is that the data from the CDC that showed new cases of kidney failure from diabetes in American Indians and Alaska Natives dropped faster than any other racial and ethnic group. It's the dark blue line on the chart that's decreasing faster than the others. And that's the time period where also there was the Special Diabetes Program for Indians. And this means less people in our communities are going on dialysis, and that's such a great outcome. And the faster decline in American Indians and Alaska Natives argues that this isn't just secular trends. The SDPI initiative had to have had an important role here with all the funds and the resources that went into it. I've actually asked a few nephrologists, and they agree SDPI has made the difference. Yet, all these great outcomes are the result of about $3.6 billion of funding since the beginning, over 25 years, for evidence-based diabetes treatment and prevention efforts in about 300 programs across the country in a system-wide, community-led intervention that required at times significant tribal leadership and tribal advocacy efforts to continue the funding with Congress. Every year at this point, they have to advocate for it. But it really shows the magnitude of effort that it takes to get these kinds of outcomes for health issues such as diabetes for our population alone. So, which makes you think of the magnitude of resources needed for other populations to get these types of outcomes as well. So SDPI is a great model for other communities impacted by diabetes, but still so much more work needs to be done on this and all other issues our communities are facing. Now, there's another part of the SDPI that I was personally very much involved in, Congress appropriated $27.4 million a year as a part of the SDPI to demonstrate translation of the latest research on diabetes and cardiovascular disease prevention in American Indian Alaska Native communities. These demonstration projects included tribal, IHS, and urban Indian health programs, and they implemented specific evidence-based activities in a collaborative team-based approach. The purpose was to demonstrate the translation of the latest research findings into real-world settings. I was really fortunate to be involved in this as the co-director of its coordinating center, along with Dr. Spiro Manson, my longtime mentor. And we had an amazing team of people working on this project. And really the most important part of these projects was that they were conducted in partnership with the local tribal communities. They had an intensive evaluation that these tribes helped develop, agreed to, and conducted it themselves. And the real heroes in this project were the teens in each tribal community who took the lead in preventing diabetes and heart disease through education, good evidence-based medical care, and community and cultural approaches. The funding allowed these communities to hire quality providers and staff dedicated to the program. The evaluation of these projects has enabled us to demonstrate that it is possible to translate research to prevent diabetes in partnership with a diverse group of tribal communities. And I have to say, I really loved this work. It was so much fun. But then in 2009, everything changed. So I ended up nominated and confirmed as the director of the Indian Health Service during the Obama administration. This kind of was out of the blue for me because I was really happy where I was at the time. But suddenly, we had the chance in this position to advocate for more funding to improve the Indian Health Service. And I was able to do what I'd hoped to do, presenting data to Congress that showed the need. So my researcher skills really helped. But while it might seem like it's the ultimate position to improve quality, managing this large federal healthcare system that is significantly underfunded, understaffed, and under-resourced is certainly a challenge. And I knew that we couldn't fix everything while I was there, but we certainly could work to make as much progress as possible, given the unusual support that we had at the time from both the president and the Congress. Now, I spent a lot of my time listening to our customers, the tribal leaders and the community members about their needs, and that helped inform our decisions. We had the almost impossible job of trying to enact policies that would benefit 574 diverse tribal nations and American Indian Alaska Native communities. But listening to these communities and seeing their successes along with their challenges was extremely helpful and really did guide our work. I considered our work a partnership, and we made those decisions based on their input. And I'm really grateful to all the tribal leaders who worked in partnership with us during that time. One lesson we learned was that enacting tribal priorities sometimes takes time. Policy work sometimes can take years. So for example, in 2012, the IHS and the VA signed a reimbursement agreement. So the VA had to reimburse IHS-funded facilities for direct care to American Indian Alaska Native veterans. This was required in the permanent reauthorization of the Indian Healthcare Improvement Act that passed in 2010. It took a couple of years to get this done, but we got it done. But it was incomplete. We needed the VA to also reimburse IHS for referral care. And despite tons of advocacy, it was not possible when I was there, but we got it started. And then in 2023, 2 administrations later and 4 IHS directors later, they finally got the policy work across the finish line. And the IHS and the VA came to an agreement on reimbursing for referral care for veterans with IHS approved referrals. So it actually finally got done. And again, sometimes it takes years to get policy work across the finish line, but the impossible can happen. We all just need to keep working together with tribal nations on their common priorities to get them to the finish line. Now, my job also included a lot of education behind the scenes in the administration about American Indians and Alaska Natives. Every time I was in a meeting with administrative officials, including this one with senior leaders and President Obama, I would raise the importance of considering the impact of every policy on American Indians and Alaska Natives and tribal nations and the importance of meaningful tribal consultation. I was relentless about this. I might have been sort of a pest, but this is the type of persistent behind the scenes policy advocacy that really pays off over time. By the end of my time in the Obama administration, people in HHS would include comments in their policy presentations about how they plan to address the needs of American Indian, Alaska Natives, and tribal nations even before I could ask the questions. So we made some progress. And that persistence and behind the scenes education by all of us helped educate both political and career staff who could help make better decisions for improved tribal policies in subsequent administrations. But it's clear that the lack of adequate resources is a huge barrier to fully meeting the mission of the Indian Health Service. And so even after we had achieved a $1 billion increase during the Obama administration, there were still disparities in funding. This graph shows the per capita or per person expenditures for IHS that continue to be lower than those for other federal healthcare sources, such as Medicare, Medicaid, and the VA. And tribes have recently estimated that instead of the $7 billion budget for IHS needs at least $51 billion in federal funding to adequately meet the need. So certainly more resources and improvements are needed, and the promise is still broken. Our accomplishments, while significant, were like a drop in the bucket of need, but I'm really proud that we did make progress during that time. I most recently worked at the National Congress of American Indians, or NCAI. Now, it's the oldest, largest, and most representative national organization serving the broad interests of tribal governments and communities, and it works to defend and protect tribal sovereignty. I was the director of the Policy Research Center, and I worked to make sure tribal leaders had the data that they needed to advocate for more services and resources for their tribal nations. And at NCAI, we also worked hard to encourage researchers to work in a real, respectful partnership with tribal nations, honoring their right to govern, honoring their culture, and building trust in a tribal academic research partnership. And during that time, working for this national nonprofit organization, it was very different from working in the government or even working in academics. I saw again how important it is to support tribal nations as they try to improve the health and well-being of their communities. They have the potential to directly address some of the social determinants of health that impact their communities. Supporting tribal sovereignty is really critical to our future. So during my time at NCAI, we experienced the COVID-19 pandemic, and it was immediately clear that American Indians, Alaska Natives, and tribal communities were going to be especially at risk. And they did have higher cases, hospitalizations, and deaths compared to other groups. And this disparity still exists today in the latest data I could find. At NCAI, we were able to see firsthand how tribal nations rallied together to protect their communities. And during the first weeks of the pandemic, when all was confusing and data was scarce, I realized, oh, I can jump in and help tribal leaders. And I gave them situational updates on the latest COVID-19 data, news clips, and regular reports. And all my experience in government helped me know about crisis management. So I was able to help in that situation, but really tallying those results every day and every week, it was heartbreaking to see cases and deaths rise each week and worrying that it might be my family that would be in those data. But I think it took the COVID-19 pandemic to really show how the disparities in social determinants of health can impact the health of a population. So while a tribal nation may have a well-functioning, perfect healthcare system, the lack of running water, sanitation systems, or adequate housing were really big risk factors. And many people were hundreds of miles away from emergency or ICU care. Still, the Indian health system, especially tribally managed programs, were able to do what they could to protect their communities, advocate for more funding, and provide much needed education on how to be safe. During the first round of COVID vaccinations, many tribal communities had the highest rates of vaccination of all communities in the country. And on the left, you can see NCAI's social media graphic early in the pandemic. And then the picture on the right is one of my mentees from the University of Arizona years ago, Dr. Raycinia James, a native physician and an epidemiologist, now working at the Salt River Pima Maricopa Indian community. And she led the first vaccination efforts for the tribal community. So again, all those people you're mentoring, sometimes they're going to be physicians working on the front lines, and they're going to do some amazing things. But again, there's just so much more work to be done. One important area that we worked in was to help provide data for tribal leaders with the NCAI Native Vote Initiative. And we provided data to show that a high turnout of the Native vote could impact the outcome in close races where the Electoral College voting margin of victory percentage was lower than the percent of American Indians and Alaska Natives of voting age in the state. So for example, in 2020, the American Indian Alaska Native voting age population in Arizona was 5.6% of all who were voting age in that state. And then the electoral victory margin for Biden was only 0.3%. So the hope is that if the American Indian Alaska Native voting turnout is high, it could potentially influence the election, especially in close races. And so we partnered with national civil rights organizations to get out the vote in 2020, and tribal nations helped get out the vote in their communities. Many tribal nations with successful economic ventures now have significant political influence because they are donating big money to political campaigns and holding politicians accountable to the federal trust responsibility. So remember to register to vote, make sure you vote. Voting is one of the most important things you can do to help improve healthcare, health equity, health policy, and in our case, to help heal the broken promise. Now, the trend towards tribal self-determination and tribal self-governance in healthcare has grown significantly since I first learned about it in the 1990s. Tribal nations now manage over 60% of the IHS budget. And here's a picture on the left of the new Oyate Health Center in Rapid City, South Dakota, that replaced that old building that I went to. 3 tribes in South Dakota recently took over the management of this health facility. And the San Carlos Apache tribal nation on the right took over the management of its beautiful new healthcare facility. And I saw hope in this trend way back in the 1990s. I am glad to see that this trend is growing, and supporting tribal nations helps meet the federal trust responsibility and is the most likely solution to help heal the broken promise. And I just want to quickly say I'm grateful to HMS for featuring the Chickasaw Nation in a recent seminar on improving healthcare access in medically underserved communities in January. I also wanted to update you that their hospital was recently designated one of the best 10 hospitals in Oklahoma in 2024. And this slide is a comparison, as the kids say, this is how it was, this is how it's going. And I was at the opening of the new Chickasaw Nation Hospital in 2010, and I even have a piece of the ribbon. And in 2024, this is my LinkedIn post 2 weeks ago that said what I truly believe. This is what's possible when we support tribal sovereignty in healthcare. So after 5 years at NCAI, about 2 years ago, I decided to leave NCAI to care full-time for my 92-year-old mother who had become very medically complicated. I'm semi-retired now and doing a little bit of academic work and a lot of caring for her. This was the right decision. She is my priority, and she is doing a lot better. This slide shows the social media mention by NCAI when I left. I am grateful to them for thanking me for my unwavering commitment to serving Indian country. That's right, after all these years, my commitment is unwavering. You have to have an unwavering commitment to do this difficult and challenging work. Over the past 30 years, I've done what I could to help heal the broken promise and improve healthcare for American Indians and Alaska Natives. It's a big challenge, and obviously, it cannot be solved by one person or one job. So many tribal leaders, tribal advocates, health professionals are working on these issues now and have made progress, but the disparities still do exist, and there is still so much to do. Improving American Indian Alaska Native healthcare, it's really a team sport, and I've been grateful to be a part of this team for all these years. This work takes a team because it is so challenging, but we need everyone to help us heal that broken promise. And I'm grateful to Harvard Medical School, Dr. Poussaint, and Dr. Reed for training me and others. We need everybody's help to expand the team of health professionals and advocates to continue to try to heal the broken promise so that American Indians and Alaska Natives can get the health care that they need and deserve. Thank you.
So I want to thank you. It's open for questions and for the impact that you've had for such a very long time and continue to have, particularly now that you've also moved into this blogging social media space and expanding your reach in terms of what you're doing. Can you speak a little to, and if you have questions, I think there's some microphones in the room. Can you speak a little to the importance of the representation of American Indians and Alaska Natives among those who are doing the clinical care and involved in the research and education? Why is representation so important? And as we're looking at these current times that can be so difficult, as we talk about diversity and other kinds of things, is it still important? And if so, why?
It's still incredibly important. And certainly I encourage everybody to work in tribal communities in the clinic or in administration or anything, because we need all the help that we can get. But there's just something about a Native physician coming into a community and taking care of their people. And I remembered how people really welcomed me and started to prefer to be seen by me because we just had that immediate connection in the clinic. But it got to be difficult for me because on appointment days, I'd be booked, overbooked, and my other colleagues would get done early and go home. And I'm like, you know, this isn't fair that I'm working harder than everybody else, but it's that commitment to those patients that you have to remember that they felt more comfortable to be seen by me because they had that certain feeling of trust that's already there. In research, it's critically important. A lot of people make mistakes in research by not understanding the diversity of the population that I mentioned at the beginning. And in administration and in policy work, it's really important for people to understand the central role of tribal sovereignty. And that's something that all of us have to do a lot to educate people on that time. So the way I think about it is that it's more about inclusion, which is inclusion of everybody in the helping heal the broken promise. I mean, if it's just American Indians and Alaska Natives trying to heal it, we're going to make progress. But if we have everybody else helping us, we're going to get a lot further. And so having a diverse workforce working on this is so important.
Thank you. Question?
Hi, my name is Charlie. I'm a student at the next door neighbor at the School of Public Health. There's some momentum going for, we're trying to lobby the school leadership and the FXP Center for Health and Human Rights to start a Native and Indigenous Health Equity Study Center. But one of the things we hear back is that it's hard to decide how to launch that. There's a sort of discomfort. Could you perhaps speak to your main recommendations on which priorities to set in the tasks that such a center should undertake?
Thank you for that question. I have been around those kinds of questions throughout my career. You know, everybody wants to establish a center. And I think that it's important to articulate not a dry, stuffy business plan, but elements of the business plan that show what is the need, what evidence do you have that this center is going to make a difference? Because there's other centers around the country, so there's plenty of examples. But there's also an issue of the reality, having been an administrator, is there's an issue of resources and funding. And so you have to think about how that work is going to be sustained. What you don't want is someone writes a grant, you get a program, and it's great for a couple of years, and the grant ends, and then the program ends. And so you want to have a sort of an institutional commitment to it. But the institutional commitment in a lot of places involves thinking about how you are going to find a financial pathway to help this continue to exist. So I was able to run programs to recruit American Indians, Alaska Natives into the health professions and research professions. But the way I did that was by finding grants and funding to do that and helping sort of build making the example of it can be done and it should be done. And here's the outcome. Like, look at the outcome of our programs. Those are doctors now. They helped save people during the COVID-19 pandemic. And it's so important to have that. I think that the reality, and I'm just going to say the reality of academic medicine is it's about resources. And you wish it was about the right thing to do, but all the academic centers I've been involved with, the resources are a big part of it. However, sometimes if you do make a good enough case, like there's so many places in the country that have Native American centers or entities and that sort of thing. But I also think it has to have a partnership with the tribal nations in the area, and that has to be really strong. And so there's a lot of work to do to establish those things, but it's worth it in the end. But just really think about, there's the perspective of the students and what they want, but there's the perspective of the administrators trying to balance budgets, and it's just a reality. But on the should it be done? Absolutely.
Thank you, Dr. Roubideaux. My name is Trini Polanco-Walters, former Commonwealth Fund Fellowship Fellow and a pediatrician. And one of the reasons why I went into medicine is because I wanted to take care of my community, similar to what you've done. And you mentioned about the importance of workforce diversity. And back in 2007, I had the opportunity to intern at the Health Resources and Services Administration. And we were working on improving workforce diversity. However, we still lack the diversity that is needed. My colleagues do not match the people we're taking care of in the community. What is it going to take for us to get there?
Gosh, if I had that answer, I'd be like so rich. No, I'm just kidding. It's going to take a lot of work. I mean, it's, when you're in medical school, you think that being a doctor is going to be this really easy, great thing. And then when you get out in the real world, you realize it's a challenging job. And especially challenging to get people who are from diverse backgrounds to be able to surmount all of the challenges along the pathway to get there. And these government programs like you worked on are so important. Programs in academic centers are so important. I go back to it's a team sport. And so trying to get together with other people who do this, going to conferences where they are and talking about their lessons learned, so you don't end up reinventing the wheel and making the same mistakes, making sure you're networking to find the people that run these programs already. And it's going to take a lot. I mean, think about the SDPI, billions of dollars and years of time to do what they've done. But the effort is worth it. And just trying to continue to build the workforce that is needed. We have research that shows if you have people from the same communities who serve their population of the same race or ethnicity, they get better care, they have better outcomes. And we need to look at the evidence for the importance of this kind of an issue. So good luck to you, and good luck to everybody working on their programs. They're so important. Next question.
I have a question from online that I had to enlarge so I could read it. Thank you. You can't do this. I'm like, are there words on the page? Okay. As a leader on multiple fronts, what personality traits, behaviors, skills do you think it takes to lead an effective Native initiatives or projects? And how did you learn them?
What leadership skills do you need? I think anybody can be a leader. It just depends on understanding your strengths and weaknesses and getting the training that you need to sort of become a leader. There's different leadership styles and different skills that you would need for different kinds of jobs. So I don't think that it's an easy question to answer. For me, your fellowship program made a huge difference. All of the training that we had. But the most thing is thinking about a leader is not the person who tells everybody what to do. A leader is someone who has to learn how to motivate people to change and to work with you. And that's a skill that often requires training, often requires a lot of practice. And so people can get leadership skills in a lot of different things. You might have a local club, you might be working for that Native American center, you might be in the local student club. You build those leadership skills over time and get the trainings you need. I was the kind of person that in the airport, you could find me in the bookstore and I was in the leadership section. I was like, stuffing a bunch of books in my backpack because I just love learning new skills because, like I said, this is difficult and challenging work. So I was ready to learn anything that would help us make progress in trying to improve healthcare for American Indians and Alaska Natives. And you have an annual leadership symposium with leadership training, and I went every year until COVID. And just those kinds of regular continuing education helps people be leaders as well. But you don't have to be at the top. You can be, you don't have to have formal authority. You can have informal authority. You can lead by influence. There's so many other ways to lead. So I guess those are some of my, comments about how you become a leader and how you get trained in that. Just practice and training over time.
Thank you. I'm going to ask one from here and then for you. Have you engaged in work with Indigenous groups in other countries working to improve their health and address historical injustice, including, say, New Zealand, Australia, Canada, Brazil, and any insights for us in terms of the United States?
Well, I'm kind of old school on this one, which is we've got enough challenges in the United States, so I chose to focus my efforts here. I could have done other international work, and a lot of people do. And that's the thing. You're not the only one that's going to solve all the problems. So there's some really great people working on the international front. I just chose not to do that because I had to save my energy for the work that I was doing. And you have to sometimes do that in your career. You can't do everything. You can't be expected to solve every problem of everybody. And so that was a choice I made early on, is I'm just focusing on federally recognized American Indians, Alaska Natives who access the Indian Health Service. Now, certainly I get criticism about all the things I don't do, but I am proud of the things I have done and have been able to focus on, because sometimes if you're not focused, you don't make you get a little progress in a lot of places or a lot of progress in one place. So I really take my hat off to all of those people working in, Indigenous areas around the world. And I know I've referred people when I've been asked to do that. I don't even have a passport. That's how focused I am on, I'm just working in the United States. That sounds weird, right? No passport, but that's my choice. I really am so passionate about focusing on improving healthcare for my people here in the US. I've chosen to just focus on that, but my hat is off to all the people that work in other Indigenous countries. It's valuable because there's lessons to learn there as well. There's a lot of good work going on in other countries that could help inform work here. So I'm just limited my capacity to help, take care of myself also.
So I like her talking about that limiting, and then you listen to all the things that she's done in all the places. And so your reach is pretty far as you talk about limiting. I will tell you on April 25th, working with HUNAP and some others, there's going to be somebody here from Australia. It's going to be talking about Indigenous health in Australia. There's a question from you.
Yeah, thank you very much. Hi, my name is Harpreet. I'm the Assistant Director for the Office of Recruitment and Multicultural Affairs. And so you mentioned how imperative it is to increase Native American representation among physicians. What can ORMA do, or how would you suggest ORMA start to initiate relationships with tribal communities in an effort to increase representation?
Right, that's critically important strategy, is starting to help tribal nations and tribal organizations understand the role they have in helping us get more doctors and more health professionals. And so you just reach out and ask to meet with people. They have a lot of people working in education in tribal nations. Reach out to Native American health organizations. Just start networking. And the thing is that a lot of people reach out to tribal nations for a lot of things. So you might go slow a little bit and start with one. But you can increase your reach by maybe attending national tribal meetings and exhibiting there, or going and networking and talking with people. You know, my mother put the idea that I could go to Harvard in my head when I didn't even think it was possible. You know, and then the brochure in the mail put the idea in my head that I could come back and get an MPH and do this health policy training. Sometimes it just takes you know, you could do this. But sometimes with students, that's all it takes, because they just haven't internalized in their mind that it's a possibility. But sometimes just mentioning it, or just helping highlight current Native physicians and for students, and doing what we used to do at University of Arizona was a seminar series. I would bring my friends in who were Native physicians doing a lot of really interesting things, and we had an endowed visiting professorship like this, that we'd bring in Native physicians, and we'd have packed rooms of American Indian Last Native students who were just couldn't believe they were getting a chance to meet these role models, and that plants a seed. That's another way to do it. So I encourage you to do it. It's really important.
I want to thank Dr. Roubideaux for all you have done and continue to do, and this persistence and this vision of possibility and of change, and of American Indian Alaska Natives leading their change. This is not coming from the outside, but coming from within. And it's about working with others in this process. Thank you for everything, for your leadership there, for your leadership in medicine. And want to add to this, this is not just leadership about American Indian Alaska Native. This is about leadership for health in America and for everyone. And what she has done has extended to our entire population. So thank you. So what I have
Oh,
to
here,
get,
microphone.
oh, but
Wait a minute. Chords.
a trip. So what I have, this says Yvette Roubideaux, MD, MPH, 2023-2024. Alvin F. Poussaint, MD, visiting lecturer, Harvard Medical School, March 28th, 2024.
Oh, thank you. Wow, thank you so much. Thanks everybody for coming. Really appreciate it.
I have to say this other part because she didn't say. Dr. Roubideaux thought that this was so important about Alvin Poussaint and the honor of being a lecturer for the Alvin Poussaint lecture. Can I tell them? That this is the first time she has come out publicly since COVID. The first time she has traveled was because of this event and Dr. Poussaint. So thank you.
Thank you so much.